Pankaj.
Good evening, all of you. Welcome you all to today's webinar on anesthesia and ophthalmology. I invite President ISMSICS MAHARASHTRA.
1 minute webinar is. Can you see my screen?
We could see it before. Now it's stopped.
Stop.
Yeah. So please start it again. Please start.
Yeah, it's coming now. It's coming.
It is coming, no?
Yeah, it's visual.
But about voice, there is no voice.
No voice is there.
No voice.
Where is the share, sir?
No, we can hear you actually, sir. We can hear you.
No, there is voiceover in that video.
Okay, sir.
Yeah. If it's working, it's fine. Otherwise, Dr. Anaesthesia, you can speak on your own.
Okay, I'll speak on my own then.
Yes,
Okay,
sir. That is
sir.
better.
Okay.
Good evening, everybody. Welcome to this episode A to Z of manual small incision cataract surgery. Today is episode 4. Can you hear now?
Yes.
Yes, sir. Yes, sir.
Audible.
Can you hear?
Yes.
Yes, sir.
No, sir. Not the recorded sound. We can hear you, but not the voiceover.
Okay.
Rahul, where is the share?
Okay, I will start my own. Okay. I will stop the voice here. Okay. Only I will show the slides. Good evening, everybody. I am Dr. Anil Shah. Welcomes you to the wonderful series of webinar that is A to Z of manual small incision cataract surgery. Today is episode 5, that is anesthesia in ophthalmology. Anesthesia is like a first date. You just have to trust it. It will work out. There are 3 types of anesthesia: general anesthesia, regional anesthesia, and topical anesthesia. For today's episode, we have, that is anesthesia in ophthalmology. We have speakers who are expert in their field with the best of their knowledge. That is Dr. Jagdeep Kakadia, Dr. Rashesh Diwan, and Dr. Jayachandran VV. And for this, we have got a discussion: Dr. Chaya Shinde, Dr. Manilal Chotalia, Dr. Gopal Arora, and Dr. Mustafa. The aim of our webinar is to popularize smart SICS, which should be soft, safe, cost-effective with minimum learning curve, and it should be useful for community basis. And our mission is to conduct series of webinar to enrich our knowledge, to popularize SICS from basic to advanced, to give recent advance to a postgraduate student and practicing ophthalmologist, and to involve surgeons to share their experience and knowledge, and to make SICS interesting and popular technique. I am thankful to all of you for giving your time and making this webinar a grand success. Thank you very much. I will hand over to Dr. Pankaj, who will continue.
Thank you, Dr. Anil Shah, sir. It was a wonderful introduction about today's. I welcome you all to today's webinar. To begin with, I would request Dr. Amul Sahu, sir.
Unmute. You are unmute.
I am unmuted.
Yes. We
Yes,
are getting you.
we can hear you. Dr. Pankaj, we can hear you. Please go ahead.
I would request Dr. Sahu sir to please guide us about the ISMICS and also about today's webinar. Please welcome Dr. Amulya Sahu sir.
Thank you very much. And Anil is doing a wonderful job. And he has the guidance of Prakash Marathe, and he is such a dedicated person. So now the speaker choice is good. Jaideep Kagadia is such a famous innovator. So nice to have his time here and all the speakers. I think many people will benefit from this webinar. Thank you so much. Carry on.
Thank you, Dr. Amulya Sahu sir. Dr. Boramani is there? Jagannath Boramani?
No, he will be.
He is going to join late, sir.
Dr. Prakash Marathe sir, please give your opening remarks.
Hello, good evening, everyone. Chairperson of ISMSICS, Dr. Amulya Sahu sir, office bearers of ISMSICS International as well as Maharashtra chapter, all the chairpersons, speakers, discussants, and each and everyone. I think this is a wonderful webinar series organized by our President, Dr. Anil Shah. And we are covering step-by-step topics, and today's topic is anesthesia. But basically what he has told about 3 anesthesias. Nowadays there is 4th anesthesia and there is no anesthesia. So no anesthesia is again one of the types of anesthesia what people try to tell in their particular patients carry forward message that they are not using any type of anesthesia. But basically it should not be the egoistic part on the part of surgeon, no anesthesia. Most of the times you need to give anesthesia, and there are anesthesias and there are complications of anesthesias. Most of us feel that it is a casual surgery, ophthalmic surgery is not that serious surgery, but there are incidences like oculocardiac reflex and so many things. So these complications to be avoided, and basic skill for this type of anesthesia will be delivered by expert speakers. And one of them is Kakadia sir, who is the innovative man whose topics and talks are very much popular everywhere. Dr. Rasesh Diwan is also there, and Jay Chandran. So I wish all the best for this webinar, and this will be the wonderful webinar for young ophthalmologists as well as senior ophthalmologists and PG students and each and everyone. This is to refresh, because most of us feel that everyone knows anesthesia. What new thing is there to learn about it? But then after listening to this particular episode, everybody will feel that this was the needed episode of this webinar series. Over to you, organizers. Thank you so much.
Thank you very much, Dr. Prakash Marathe sir, for giving and guiding all of us. So to start with, I would like to introduce today's chairpersons and esteemed faculty for the webinar. We have Chairperson Dr. Prakash Marathe sir, who is a Managing Committee member of AIS 2023. He is past President of MOS, POS, IMA Pune. He is a National IMA Convener and Standing Committee member, Prevention of Diabetic Retinopathy Blindness. He is Chairman of Maharashtra chapter of ISMICS also. The next chairperson is Dr. Anil Shah. He is President of ISMICS Maharashtra chapter. He is a private practitioner from Nandurbar. He has received many awards from MOS, mainly for snare and large foldable IOL for MSICS. He has published books and articles and master guide for MSICS and various international presentations and paper publications at national level. Next chairperson is Dr. Shekhar Paranjpe. He is a scientific committee member of ISMICS Maharashtra chapter. He has worked relentlessly for eye donation in Western Maharashtra and is passionate about sports of alpine snow and skiing. We have eminent Dr. Professor Rajesh. He is the editor of Journal of Clinical and JCOR of Maharashtra MOS. He is member of FAICO AIS, past secretary MOS, and president of Nagpur and Vidarbha Ophthalmic Society also. Today's esteemed faculties, we have very renowned Dr. Jagdeep Kakadia sir, who is LLB and PhD too. He is dynamic surgeon with vast experience in all ocular surgeries. He has invented autofocus pro IOL, Omni Glow device, OmniFlow glaucoma drainage device, UV Glow for C3R, JK Pro, Kiraglow capsulase, ILS 2020, Axion Torilase, Reticlow, glaucoma, capsule opener, and Stellar Flow also. It would be a treat to listen to him and we eagerly look forward to hear you, sir. Next speaker is Dr. Rashish Diwan. He is MD DA. He is past president of Gujarat State ISA. He is a national trauma faculty. He has 5 international and 4 national publications. He is a faculty of World Congress of Ophthalmic Anesthesia, DNB PG Guide, and Executive Board Director, Academy of Traumatology, India. Glad to have you, sir. Third speaker we have is Dr. Jayachandran VV. He is a Deputy Director, Department of Anesthesia, Hospital Safety Committee, Shankara Netralaya, Chennai. He is a founder and secretary of Association of Indian Ophthalmic Anesthesiologists. International President for World Congress of Ophthalmic Anesthesia, 2020-24. President-elect, Chennai Metro ISA branch. He has developed real-time view mannequin for needle blocks and subtenance block simulator along with IIT Madras. He is a chief editor of Principles and Practice of Ophthalmic Anesthesia by JP Brothers. Welcome you, sir, for today's webinar. For next proceedings, I hand over to the co-moderator, Dr. Rujita Machwe. Please.
Thank you, Dr. Pankaj. After all the presentations are over, to have fruitful discussions, we have invited senior ophthalmologists as discussants. Dr. Chaya Shinde, madam. Welcome, madam. She is professor and head of ophthalmology, Lokmanya Tilak Municipal Medical College, Sion, Honorary Secretary, National Society of Prevention of Blindness, Mumbai branch, member Medical Education, Lokmanya Tilak Municipal Medical College, member Curriculum Committee, Medical Education Unit. She has contributed chapter on eye care in Braille book, and that's really commendable. Contributed as speaker in various national and international conferences, national webinars. She's got 58 scientific publications. Bell Pharma Award she has received from MOS, Women Achiever Award from Lions Club Bombay, and other Shikshak Puraskar from Mahavir International Mumbai. Welcome, madam. Our next discussant, next slide please. Dr. Manilal Chotalia is past president AGOS 2005-6, past president ISMSICS Gujarat chapter, past secretary ISMSICS Gujarat chapter, founder president Junagadh Ophthalmic Society, and he is past MS Ophthalm from PJ Medical College. Welcome, sir. Our next discussant is Dr. Gopal Arora, director of Akshar Eye Institute, Nagpur, youngest president of Nagpur Academy of Ophthalmology in 2004, president of JCI Nagpur Medicos, was president of Vidarbha Ophthalmic Society, president of Association of Medical Faculties in 2014, past president of MOS, organizing chairman Moscow in 2013, director Medical Services of Rotary Club of Nagpur, and he has won prestigious awards like V.K. Chitnis Oration Award, Dr. Ishwar Chandra Award by MOS, Dr. Ranjan Roy Memorial, ACO and WP Oration by Community Ophthalmists of India. Welcome, sir. And our last discussant is the international faculty, Dr. Mustafa Bature, honorary consultant at Usmanu Danfodia University Teaching Hospital, Sokoto, fellowship of West African College of Surgeons, member of Royal College of Surgeons, Edinburgh, fellow International Council of Ophthalmology, Eye Health Heroes Award. He has many awards to his credit, Annike Abiose Award, Surgery Award. Welcome, Dr. Mustafa. Now, without further ado, may I invite our first speaker, Dr. Jagdeep Kakadia, sir. As we have seen in his CV, he has got an array of inventions to his credits. He is not just ophthalmologist, but he has an LLB also. So welcome, sir, for your talk. And the topic is regional and topical anesthesia, merits and demerits in manual SICS. Welcome, sir.
Thank you very much, ma'am. I would start my presentation to save time straight away. Hello, dear friends and colleagues. Today we are going to discuss practical tips and points and pearls of wisdom of ophthalmic local anesthesia in this video. Before we begin, let us first pay our deep respects to Dr. William T.G. Morton, who on 16th October 1846 at the Massachusetts General Hospital in Boston induced mankind's first general anesthesia by using ether as general anesthetic in this amphitheater OT, which is now a memorial museum, famously known as the Ether Dome. For every surgeon and anesthetist, the life is incomplete without visiting this pilgrimage place, the Ether Dome. Let us also pay our deepest gratitude and homage to Dr. Karl Koller, a pioneer of local anesthesia, an eye surgeon from Vienna, Austria, and who later became a resident of New York. In 1884, he first induced local anesthesia by using coca leaves extract instilled on cornea and conjunctiva to do ab interno one-graphy incision cataract surgery, which essentially was a topical anesthesia surgeries in those days. We have no financial interest in anything we are presenting in this video, and you all are free and requested to take screenshots as and when you like. At the outset, we heartily thank ISMSICS and all these office bearers in general, and Dr. Anil Shah of Nandurbar in particular. There are three types of anesthesia: general, regional, and local. General anesthesia in ophthalmic surgeries are mainly needed for kids, completely deaf who are also dumb, profound mental retardation or CP persons, profound language barrier, epileptics and schizophrenics, severe claustrophobics, and severe Parkinsonism or senile head tremors patients. Majority of all eye surgeries are preferably done under local anesthesia. There are two types of local anesthesia, akinetic and kinetic. Akinetic anesthesia are induced either by sharp needle techniques, in which there are two. One is known as retrobulbar, which is also known as intraconal, plus or minus the facial block, or two, the peribulbar, which is known as extraconal block, or induced by blunt cannula technique, which is known as subtenon, or also known as parabulbar block. Kinetic anesthesia, known as topical, which is most favored in cataract and laser vision correction surgeries. For the local injection blocks, lidocaine 2% with 1 in 2 like adrenaline is generally preferred by most eye surgeons. Our personal preference is to add 0.5 ml of epitrate, which is a preservative-free adrenaline, to 30 ml of 2% plain lignocaine to make a 1 in 1 lakh adrenaline concentration, which is higher or double than the previous one. For longer lasting surgeries, we prefer to use 1 in 80,000 Lignox A. These higher adrenaline concentrations have several advantages. One, it gives 2 hours long duration of action without the need to use bupivacaine or ropivacaine, and gives almost bloodless field without any allergy because the epitrate is preservative free. At this power, adrenaline is also a mild bronchodilator, anti-anaphylactic, and gives a mild tachycardia, preventing vasovagal or oculocardiac bradycardia. Enzyme hyaluronidase temporarily and reversibly depolymerizes hyaluronic acid. This creates microchannels in the interstitial matrix that allows fluids to flow through, and hence diffusion and spread of the lignocaine anesthetic is facilitated. Hence, adding the enzyme hyaluronidase as 50 to 100 international units per ml is very essential. This can be done by adding 1 ml distilled water or lignocaine 2% to the hyaluronidase vial, and when the enzyme powder is dissolved, take it back into syringe and return it back to LOX to 30 ml vial. My personal preference is to add 2 vials of hyaluronidase to 1 bottle of 30 ml LOX, making it 100 international units per ml. Over and above the 2 hyaluronidase, my personal preference is also to add 2 ml, that is 8 milligram of dexamethasone, to this 30 ml of Lignox A. So now in this 32 ml, there is 0.25 milligram of Dexona per ml. This gives very quiet eye and anterior chamber, and also the next day orbital angioneuritic edema, which we face occasionally, is completely prevented. My staff has happily named this cocktail as Loxtail. Retrobulbar block is deep and intraconal, whereas peribulbar is equatorial and extraconal. Venous, or more dangerously the arterial retrobulbar hemorrhage, often with optic nerve compression leading to amaurosis, with proptosis and raised intraocular pressure, and many other complications have made the retrobulbar block almost an abandoned procedure now. Peribulbar, the safer version than retrobulbar, also has a complication of post-optosis in some patients due to the upper lid injection. Also, at times, we get ecchymosis and sublingual hemorrhage, so we have abundant perivulvar also. Topical anesthesia is much safer and much preferred in cooperative patients for phacoemulsification or femto procedures. Most of us use proparacaine 0.5% eye drops or preservative-free 1% lignocaine injections, Oculan, as eye drops. My personal preference is to use 4% LOX topical eye drops for topical anesthesia. 4% LOX with moxicate, 1 drop from each bottle, 4 times at 1 minute's interval, just before we start painting and draping is excellent for good topical anesthesia for phacoemulsification, femtophaco, LASIK, or LASIK. We always take a vein kept ready for IV because in topical, extraocular muscles, uvea, and retrobulbar stretch receptors are not anesthetized completely. There are chances of oculocardiac bradycardia, especially in patients who have high vagal tone, as is indicated by hyperacidity and acid peptic disease, or those who have bundle branch block or missing heartbeats. In a cooperative patient, even pterygium surgery can be performed with LOX 4% as topical. We supplement the topical with intracameral Oculan, which is a preservative-free 1% lignocaine used in 1/2 dilution in BSS. We can also use Loxicard, which is a preservative-free 50 ml vial to be used in 1/4 dilution in BSS. Being hydrochloride salts, lignocaine can be autoclaved multiple times so that we can keep these in drums and take on trolley to be handled directly by the scrubbed assistant. For the MSICS or ECC or a possible conversion, our most favorite and preferred block is subtenon, which is the safest because it is given by blood cannula and not by a sharp needle. So it is safe even in pathological myopia or scleromalacia. A single injection of 4 ml is sufficient. It has fast action. It works in 2 to 3 minutes without vasovagal or oculocardiac reflex, and it gives almost complete echinacea even of eyelids. There are 3 types of subtenon cannula: tripod, flat front, or a single side hole. My personal preference is to use a tripod 21 gauge cannula, which is autoclavable and reusable n number of times, having 2 side ports and the front port. Please notice that the front end is rounded and atromatic like a fingertip. Giving a nice spread of lignox all around the eyeball. Even if the front end or one side port is blocked by the soft tissue, lignox will still spread and well and easily. This is made by Precon and bears our initials J011C, 21 or 19 gauge. Let us see step-by-step videos of giving subtenon block. First, we degrease, clean, and disinfect the skin with 3 or 4 ethyl or isopropyl alcohol wipes, wiping in centrifugal fashion, and then put LOX 4% with moxicate eye drops, 1 drop 4 times at 1 minute interval to numb the conjunctiva, and then a cotton-tipped Q-swab dipped in 5% betadine is squeezed to put few drops in the cul-de-sac. And then eyelids and the area around the eye is painted with betadine. Preferably, for most comfort, patient's head, mainly the eye, should be at the level of surgeon or anesthetist elbow point. Doctor should stand or sit on a stool depending on the height of OT table or block table. Now, mount the cannula on a 4 to 5 ml filled syringe in such a way that the convexity of the cannula is facing towards the ml marks of syringe. so that surgeon or anesthetist can see marks clearly and control the volume and speed of injections while pushing the piston. Since the inferior nasal quadrant is the least crowded of all, and since ciliary ganglion is nearest via this route, subtenon blocks are always given via inferior nasal quadrant route. Now, we put the mounted syringe on a side table on a sterile surface and then insert the wire speculum. Now, asking the patient to look up and out towards the corresponding shoulder of surgeon or anesthetist to expose the inferior nasal quadrant as best as possible. The conjunctiva is grasped with non-tooth Murphy's or Fashioner ring forceps about 7 millimeters away from the limbus, and the conj is pulled to create a tiny triangular tent, and then a tiny nick is given by Westport scissor, keeping the tips of the scissors perpendicular to the conj, and then a little blunt dissection is done. The blunt dissection is done in such a fashion so as to expose the bare sclera, which is simple and easy. Now, holding the tiny conjunctival flap, the subtenon cannula is inserted, keeping the concavity facing the sclera. The cannula, always snugly abutting in close apposition to the sclera, is inserted till the hub touches the conjunctiva. And then we slowly inject 4 ml over a period of 1 to 2 minutes, keeping the patient always hooked to the pulse oximeter, which is having audio feedback and alarms facility, not the simple finger ones, but the bigger one. Keeping eyes and ears on the pulse rate. Please notice that there is no ballooning or chemosis of the conjunctiva, even after giving full 4 ml. The speculum is then removed. And the eye is gently pressurized with pressure off and on under a pad or a gauze piece, making sure that the lid is closed and the cornea is not being abraded during the pressure. Pressure is given for about 3 minutes. As you can see that in 3 to 4 minutes, echinacea of the globe as well as eyelids is complete. For thin, lean persons with sunken eyes, we just need 2.5 ml of Lignox. For normal persons, 4 ml, and for big, chubby, fatty, and prominent eyes, about 5 ml. In this way, the subtenon block is completely painless, is as close to topical as a block can be. For patients, it is quasi-topical, and most of them are happier with subtenon than under topical. There is no need to cauterize or close the tiny conjunctival puncture. It is self-sealing and self-healing. In over 65,000 cases, we have never encountered oculocardiac reflex. Also, we never had postoperative ptosis in any patient. Yes, we have to keep pad and patch for 5 to 6 hours, but the eye is fully open when we open the pad, and there will never be diplopia, nor the post-op ptosis. Subtenon block is so gentle and soft without much IOP rise, so even during topical surgery, this can be given if the patient has become uncooperative midway the surgery, or if we need to convert. We can give this block even without removing the drapes. Please notice that we have to keep anterior chamber well filled with visco if we have to give mid-surgery subtenon block. For intra-op subtenon, if you use 4% locks with hynidase, just 1 to 1.5 ml injection is sufficient to get full echinacea. The surgeon and not any assistant can carefully give this even with 26 gauge 1-inch needle if the cannula is not available on table. This video is just to emphasize that the cannula's concavity should be facing the convexity of the scleral contour, and that it should be snugly awaiting the sclera and go deep till the herb is in contact with the conjunctiva. Also, please notice the relation between the ML marks of the syringe and curvature and convexity of the cannula. This is an interesting modification we accidentally found because once the Westport scissor had fallen down. We can use 18 gauge disposable needle bevel up to create an entry point in the conjunctiva and also use a methyl viscose cannula to inject Loxtail. Of course, the tripod dedicated cannula is the best to use because its curvature is conforming to sclera's shape. This is another interesting modification where we can use 18 gauge disposable needle for the conjunctival entry and use 20 gauge Venflon in place of the tripod cannula. Lift the triangular tent of the conjunctiva. Enter with the 18 gauge needle. Bevel down. We can use bevel down or bevel up. And this is the Venflon, 20 gauge Venflon. Of course, per unit cost of 20 gauge Venflon is very high, 235 rupees. But we can buy 20 gauge 100 units box from Amazon for 1550 rupees. That is approximately 16 rupees per unit. Moorfield's conjunctival forceps is also available on Amazon. We can use these Fachner mini ringed conjunctival forceps also. These dental tweezer forceps, almost at the cost of disposables, are also an excellent atraumatic alternative to the dedicated conjunctival forceps mentioned before. Before we conclude, we request you all to please take a screenshot of this slide and please see all of these very useful detailed videos about how to achieve zero endophthalmitis and zero TAS in intraocular surgeries. And also, please take screenshot of this slide and at your earliest convenience, please see all these 6 videos about our important and useful innovations. With this, we thank all our anesthetics colleagues and friends, and also we thank the ISMSICS, especially the Maharashtra chapter, as well as Entered Pharma for web and IT support. Thank you all attendees for kind attention and patient listening.
Thank you so much, Dr. Kakria, sir. Your talk was wonderful and elaborate as always with wonderful videos and a lot of take-home messages. Thank you so much, sir.
Thank you.
I now invite the second speaker, Dr. Rasesh Diwan. The topic is life-threatening complications following regional anesthesia, its prevention and management. Over to you, Dr. Diwan, sir. Please unmute yourself.
Thank you so much, Dr. Rujuta. And I just start my presentation first for sharing, and then I'll start talking. It's really a great pleasure to be in the Maharashtra chapter and ISMSICS webinar on ophthalmic anesthesiology. I feel overwhelmed, but I feel my friend Dr. Jay also must be feeling very proud moment, because such a large teamwork I'm seeing in the Maharashtra chapter today. So many people taking care of the webinar. It's a great moment for both the anesthesiologists to join this webinar. Anyway, I'm coming to the topic. That was a wonderful presentation from Dr. Jagdish Kakaria, and I know him for more than 25 years. He's an innovative engineer in ophthalmology. So in my lecture also, he's going to give us the tips on the surgeon's perspective at the end of the webinar. So we talk about the life-threatening complications, and we all know why there are more such complications. And eye is such a small part, but eye is a part of the brain, and its meningeal layers extend over the optic nerve. The optic sheath is continuous with the subdural and subarachnoid space. The blood supply is to the central nervous system supply, and it is very rich in autonomic nerve supply. These are the reasons why any inadvertent needle placement or little deviation from the standard technique can create a life-threatening complications. Actually, the incidence of such life-threatening complications is very low, but the magnitude of the problem it arises and the way in we have to manage and resuscitate the individual is really difficult in an ophthalmic setup. So let us discuss these common complications. And why it is important is to know correct technique and individually tailor-made technique for individual eye is because of the anatomical architectural variation in the orbit, in the orbital content, and discrepancy in the orbital space and globe volume and shape. Sometimes it's a long eyeball, sometimes it's a short eyeball, sometimes the eyeball is placed outside proptotic and a lot of connective tissue behind. Sometimes the orbit is very shallow and hardly any needle depth available at the apex level. And most important point is a blind placement of a sharp needle. You can see the eyeball proptotic. Now, you know, it's only you see the palpebral fissure and the eye globe outside the conjunctival surface, but the needle goes just blind, and particularly high myops, and we usually know this big staphylogram or something, the chances of globe rupture or perforation is commonly noticed. So what I'm going to stress is there are complications like which are purely simple local ocular and systemic. My concentration for this presentation is mainly on the systemic complications, and I grouped them in 3 types: the intra-arterial injection, optic nerve sheath injection, and oculocardiac reflex. Now, the first 2, intra-arterial injection, where there is a retrograde flow of the local anesthetic into the ophthalmic artery. Now, when it is intravenous, by accidentally you inject intravenously, the drug goes first in the general circulation to the heart. So heart complication can arise mainly if you are having adrenaline in the dose Dr. Kakaria suggested can cause tachycardia and cardiac arrhythmias. But serious complications are delayed and very less and with a less magnitude. But if it goes arterial, then it is very serious matter. Fortunately, since we have shifted from retrobulbar to peribulbar and subterenous and topical, the first 2 complications and more understanding the anatomy and technique, the intra-arterial injection and optic nerve sheath injection complications are very minimal in last 2 decades. But oculocardiac reflex, irrespective of your expertise, irrespective of your knowledge and wisdom, irrespective of your experience, can happen anytime to any patient, and you need to recognize it very quickly. So these 3 I am going to describe. First, as I said, there is a reversal of the flow into the ophthalmic artery, and the drug can go up to the anterior cerebral artery or sometimes up to the internal carotid artery. And there is an access up to the midbrain with the recirculation, and you get all the symptoms of midbrain structure involvement, particularly the vital centers. The incidence is reduced because of more use of peribulbar these days, but still we have to keep it in mind that this can happen. The symptoms you get is immediate convulsions and cardiopulmonary arrest. Now, these are very dreaded complications, and with the ophthalmic setup, sometimes we are not fully equipped to manage cardiopulmonary arrest in an individual, and we take care of the people who are middle-aged to elderly population having a lot of comorbid cardiac conditions, and they are on various medications. So these are the people most vulnerable. See, if they get the complication, it is really very difficult situation to manage, and it requires very aggressive resuscitation. Second is the optic nerve sheath injection. We commonly call it brainstem anesthesia, where the mechanism is subarachnoid injection via puncture of dura mater sheath of the optic nerve with a long retrobulbar needle. Or sometimes with a shallow orbits in a small eyeball, and your needle is longer, you can reach. Sometimes there's in 40 millimeter, you reach to the apex of the orbit and you directly inject, which is the subarachnoid space within the cranium. These are the mechanisms of brainstem anesthesia. And this has been experimented on the cadavers with the CT scan contrast. You inject in the dye, either radio-opaque dye or methylene blue, and then you do dissection. The dye or the drug has been found out right up to the midbrain or in the subarachnoid space. And these are the cadaveric studies performed a long time back in 90s. I am presenting a very old study. Nowadays, no recent studies are there on brainstem anesthesia because the complication is much lesser in incidence nowadays with the newer techniques of regional anesthesia. But 1 out of 350 to 500 in a multicentric study in UK, this has been noticed with CNS involvement of about out of this 0.27%, apnea in 0.79%, and mainly this has been found that intra-optic sheath injection was observed. While with the peribulbar also the incidence is very, very low. In the same study, it has been about 0.02%, and the same in the incidence with subtenons almost. And in subtenons also, because probably we are less serious about the complications or even the death also has been reported. And this is one brainstem anesthesia case report of 75 years old lady with peribulbar block, and it was published in 97 in the Canadian Journal of Anesthesia, who required not only simple resuscitation, but ventilation and hemodynamic support, and patient was recovered after about few hours. What I want to stress upon is you should be prepared for an aggressive resuscitation and ventilatory and hemodynamic support to these individuals. Usually the clinical presentation in brainstem anesthesia is the intensity of signs depend upon the direction of the spread and extent of the spread, which is volume dependent. The onset may be in seconds to 40 minutes. So even the surgery is finished and you need to observe these patients, or you don't discharge them in 5 minutes sometimes, particularly when you've done the retrobulbar block. And commonly the symptoms are observed in about 5 to 10 minutes. The common signs are they start with the confusion like any local anesthetic toxicity, but this is actually not the local anesthetic toxicity of the central nervous system. It is a direct block with the drug going in the subarachnoid space, and there is a dizziness, blurring of vision, tinnitus, hearing loss, dysphagia. These are the common symptoms they start narrating. Then there's multiple cranial nerve involvement, contralateral hemorrhages. You all know what it is. You lose the vision on the other side, and it is sometimes area-specific dependent, depending on the loss of physiological function and which area is blocked. And lately they get the conversions. Now the signs symptoms are mainly which we are worried about are the cardiovascular and respiratory. There is the involvement of vital centers and may lead to death. There is a respiratory depression and apnea which needs ventilatory support, and there may be bradycardia, later on hypotension, and may lead to even cardiac arrest. So management as such is not complex. What you need, like any high-risk patient getting cardiac complication, in resuscitation area, we give IV fluids, vasopressors to maintain the blood pressure, vagolytic drugs, and anticonvulsants if they get the seizures. On the other side, if the patient develops loss of consciousness, you need an airway management. If the patient stops breathing, then you need to intubate and mechanical ventilation is necessary. If they get the cardiac arrest, then you need a very high performance CPR and advanced support. And ultimately then these victims will end up in a good critical care backup. So that was about the oculocardiac, brainstem anesthesia, which we'll discuss later on in the question answer. Third complication which we see where many times, even with the wisdom and experience, we feel we have no control, is the oculocardiac reflex, which is a trigeminovagal path. You all know that, I don't need to describe this. Usually there are stimuli from the orbital structures. Mainly we see in the squint patients, squint surgeries, the traction of extraocular muscles, and sometimes even in the vitreoretinal surgeries. But more commonly during anesthetic procedure, we get the pressure on the globe, which when we put the super picky ball, we were used to use many years back. We have stopped using almost from 2000, but we give a gentle digital pressure also sometimes. That can lead to bradycardia or oculocardiac reflex. But most common is the volume we inject inside the orbit. If it is injected very fast and the excess volume is given, then the capacity of the orbital volume, then it can cause oculocardiac reflex. And among the anesthesia techniques, it has been observed more commonly with the retrobulbar technique. What you observe is a bradycardia or sometimes leading to asystole and sometimes even ventricular tachycardia and arrhythmias. So it is very important that you monitor this patient with the EKG and pulse oximetry. So the management, everybody knows the first step is to release the stimulus. If you are pulling the muscle, you are in the squint surgery, even with a very good perivalve, sometimes you get it. More common it is, I have observed, is under the general anesthesia. So you release the stimulus, we have to instruct the surgeons, please release it, wait for some time, let it recover of its own, and closely monitor the patient. And most of the time it recovers. There may be more than 20% reduction in the heart rate, which recovers very well. And you need to very closely monitor this patient. If it doesn't recover in 30 seconds to 1 minute, you give atropine. Now, usual dose, we go by the kilogram per body weight, but I recommend 0.6 to 1 milligram. In India, we get 0.6 milligram atropine infused, but actual dose is 1 milligram. So you may have to give 1.5 or little excess atropine from the another ampule. That is what the international recommended dose nowadays. It is preferred to have an ECG monitor even while administering atropine, because sometimes with an active reflex, which is not recovered completely, and you give atropine, sometimes there are arrhythmias we need to pick up immediately on the ECG monitor. However, there is no role of injection atropine in prevention of oculocardiac reflex in adults. It has some role in children when you are doing squint surgery under general anesthesia. Glycopyrrolitropin has some preventive role. Additionally, even under general anesthesia, if repeatedly there is an oculocardiac reflex, we give local anesthetic block. We infiltrate in the subconjunctival infiltration, mainly not in the muscles, because that muscle you are going to dissect. And little deeper plane of anesthesia and opioid analgesics to some extent prevent the subsequent oculocardiac reflex. Now, to prevent some life-threatening complications, I'm giving some tips. We prefer shorter needles nowadays, not more than 28 millimeter or 30 millimeter. So it is little, maybe less than 1 inch. So when you put the whole needle inside, most of the time it is not beyond the posterior pole of the eyeball. Irrespective whether you are doing a lower temporal block or lower nasal block. Now, orientation of anatomical variations is very, very important, and I don't have to reinforce to the ophthalmologist when I am talking, but I take a lot of precautions for understanding the anatomy being an anesthetist. So you must learn the correct technique. Now, superior nasal site was recommended by David Davis in 1989, from whom I had learned peribulbar in 1989. It is not a safe place. The reason being, at that area, sometimes the orbit is, a globe is undermined and you have to go a little upward. So there are high chance of perforation, as well as there are more venous vasculature. So there are more chances of going intravenous or having an peribulbar hemorrhage. So we recommend not to use the upper nasal side for the infiltration. Best is to use the lower temporal and subsequently like medial canthus block, the percutaneous medial block, which is exactly perpendicular, parallel to the medial wall of the orbit. Now, we strongly recommend patients monitoring in ECG and pulse oximetry, absolutely mandatory for all the patients, always aspirate before injection, and my practice is to have always IV access like what Jagdish Kakadia showed to every patient. Since 85, I am practicing ophthalmic blocks. I have never done any patient without an IV access. This book picture is given in all the textbooks and guideline books. When you give the block, use the primary neutral gaze position. That keeps the optic nerve loose. And if your patient tries to look up and towards nasal area, it comes in the way of the needle and it becomes tight. So the longer needle retrobulbar complications are very high if your patient looks in a different position. So you must have the neutral gaze, which probably everybody knows this. I don't have to emphasize much. And this is how I usually stand on the head side. This is how the patient looks at me when I initiate the block. I have always axial length in my mind. I keep the primary gaze, judge the volume available in the orbit to inject. From the orbital diameter, from the axial length, how much eyeball is proptotic, and I press over the eyeball before giving the block. How much is the mobility of the eyeball within the orbit? So I judge that there is adequate connective tissue in the orbit to accommodate the volume I am going to inject. And initially, I give a 0.5 ml injection subcutaneously for the analgesia of the skin. Subsequent block I give after a minute or two so that patient is absolutely pain-free. And I'm trying to show a video where I've already done the local prick. And this is my very old video, probably 93 or 94, when we were doing the colloquium and I showed the technique. The thing I want to explain is the speed of the injection. You should be doing very, very slow. I take sometimes almost 45 seconds to 1 minute to finish one prick peribulbar and inject it very, very slow. And I stop when I see the upper lid starts closing. You can see that. Probably everyone's practice is this. So sometimes I get this in 3 ml. Sometimes I don't get the closure of the lid even in 6 ml. So my volume decision is depending on first the orbit size and eyelid closure so that I know this volume is adequate. And probably 90% of my blocks are with single prick only. And I get nearly 100% akinesia in all the recti muscles. So final recommendations which I want to give for prevention and understanding the regional anesthesia is don't be in a hurry to give local anesthesia. Take your ample time. Talk to the patient. Keep talking in between also. That helps us to judge the sensorium of the individual. And be in a hurry. I'm an anesthetist, so my surgeon may be in a hurry, but they know me that I'm going to take my own time. So there's no point in standing on my head. Second is, I always use all electronic patients monitoring devices in the operation theater, and oximetry and ECG monitor is must before starting the block procedures. OR should be fully equipped with resuscitation equipment. Probably Jayachandra is going to talk about that, and all emergency medicines. And also, you need the knowledge and skill for resuscitation. And I reinforce, I repeat, strongly recommend every ophthalmologist, every paramedic working in the ophthalmology or operation theater should do certified basic cardiopulmonary resuscitation course. The reason I am telling is we all in our career with 35 years, 40 years practice, we see some serious complications. In spite of our best skills, best knowledge and experience, we get such patients serious sometimes in the operation theater. If you are not fully learned the basic cardiopulmonary life support resuscitation, we may not justify making that patient survive and do any aggressive resuscitation. The reason being, incidence of serious complications is much less, but the magnitude of the problem is really disastrous. And I'm sure every one of us have faced this situation in the operation theater. I have left many things unanswered in this presentation, but we can have time to have the question and answers from the chat box and from the all the moderators. Thank you so much. I again thank the committee for inviting me and asking me to share my views on the serious complications in regional anesthesia. Thank you so much.
Thank you so much, Dr. Diwan, for a wonderful presentation. It was a real eye-opener, and hats off to you. You take such meticulous precautions before starting any kind of peribulbar or any kind of block. Thank you so much. And I know there will be a lot of questions after we finish our presentations. So now may I request our third speaker, Dr. Jayachandran VV. He'll be talking on pre-op evaluation in adults and pediatric age group, life support equipments, and common and emergency drugs in anesthesia. Over to you, Dr. Jayachandran.
Good evening, all. Let me share my presentation. So the topic which Dr. Anil Shah wanted me to cover is that preoperative evaluation of patients. So this is how I thought I will approach this topic. What is preoperative evaluation? Why and how it needs to be done? Now, many of them think that preoperative evaluation only you should do systemic examination, but most importantly, for regional anesthesia, we should assess the globe and orbit relationship also in the preoperative period. Also, what are the basic investigations you need to carry out? What are the instructions and advice you will give? And preoperative preparation of the patients on the day of surgery, I will be covering. Also, Dr. Anil Shah wanted me to cover some emergency medicines and emergency equipment that has to be kept in the operation theater. So lastly, I will be covering those. What is preoperative evaluation? It is nothing but a process of clinical assessment that precedes the delivery of anesthesia care for surgery. Why it needs to be done? Now, many patients posted for cataract surgery, as you all know, are elderly, and they come with a lot of multiple systemic comorbidities, which needs to be recognized, and sometimes they need to be optimized also. It also helps one to identify high-risk cases. Helps to establish a good rapport with your patient and answer all their concerns. And finally, to draft any particular perioperative plan, taking into consideration the various medical and surgical factors. How it is done. Now, in the developed countries, self-administered health questionnaire is given and an appropriately trained nurse undertakes this preoperative evaluation. But unfortunately, in developing countries, especially in India and some of the developing places, there are barriers to this process. There can be a lack of knowledge, illiteracy, language barriers, etc., etc. So finally, it is the responsibility of the doctor to do a proper perioperative assessment. Basically, this preoperative evaluation consists of three components: a detailed, comprehensive history, thorough physical examination, and selected laboratory test. First and foremost, with regard to the detailed systemic history, I think everyone will be insisting on asking these questions. That is, history of any previous medical illness and medication history. Now, with regard to the regional anesthesia technique, what is the thing you should look into or ask to the patient is the history of any allergy to local anesthetic cells previously, any tablets, any injections, food allergies. Then, most importantly, history of any post-operative eye contralateral or facial swelling following previous eye surgery. This is very, very important because half late what we have come across is hypersensitivity to hyaluronidase reaction. Okay. So this hyaluronidase, it requires a presensitization, and many times what happens, a patient would have undergone surgery elsewhere, and the second time they would have come with a eye swelling. For the third and fourth time, the eye swelling will be much more worse. So you should ask the leading questions, whether following previous eye surgery, whether the patient had any post-operative swelling. In these patients, it is better to avoid hyaluronidase. This is very, very important take-home message which I want to stress in this presentation. Also, you should find out whether the patient is high myope or single-eyed patient. Reason, you should be doubly careful in performing needle blocks or safer to perform subtenons or topical anesthesia. Then, also find out whether the patient has undergone any previous eye surgery, especially vitreoretinal surgeries like encircling scleral band. The reason, the hourglass effect. The posterior part of the globe is more vulnerable to get iatrogenically damaged by the needle, and also the scleral expanse can cause physical obstruction to the needle advancement, and also the scarring can prevent adequate spread of the local anesthetic solution. Then, the history is over. Coming to the systemic examination, mainly we will look into the cardiovascular system for any murmurs, respiratory system for any basal creps or rhonchi. If symptomatic, the patient has to be optimized, and sometimes we need to do investigations also. Now, coming to the ophthalmic part, what we need to examine with regard to the regional anesthesia techniques, the globe and orbit relationship, which many times even the ophthalmologist tends to ignore it. So it is very important to assess this globe-orbit relationship. Now, how to assess it? They say that the average distance between the infraorbital rim and the top of the cornea, it should be about somewhere 8 millimeters. That is, if you make the patient lie down flat, and if you keep a scale at the level of lateral limbic line over the infraorbital rim, as you can see in this picture, this is a deep set globe. The top of the cornea is somewhere around, I could say, 2 millimeters. So deep set globes. Associated features are short, tight lids. Whereas here we see that forward set globe, the top of the cornea is somewhere around, I could say, 13 millimeters. So it's a forwardly placed globe. And associated features, there can be lax lids, wide palpebral fissures, and eyebrows. What is the importance of this? In deep set globe, you should not angulate or penetrate the needle too much. There can be chances of globe puff. And in forward set globe, there are high chances of needle hitting the most important structures in the apex like ophthalmic artery, optic nerves, and vessels. So these are all some of the abnormal globe-orbit relationship which we may need to block. So you should be very careful in these cases. Also, during the perioperative period, you should look for any septic foci. So coming to the investigation part, the routine preoperative medical testing is widely practiced despite international evidence-based guidelines which recommends that these are not necessary. Now, many of the places, investigations are tailor-made and individualized according to the patient's medical and surgical conditions. Each individual's institution have their own protocols. Finally, the clinical judgment should determine the need for more extensive investigations if there is any positive findings in the history or in the physical examination. Now, this is what we follow at our institution routinely for all patients. Routine lab investigations we undertake is total and differential count and urine routine. For diabetic patients, apart from this, we take urea and serum creatinine. For patients with known chronic renal failure, apart from this, we take serum electrolytes and basic coagulation test. For oculoplastic cases, basic coagulation test is done. For patients above 40 years, we insist on ECG. If GA, chest X-ray is advised. So these are all the instructions which we carry out, especially the patient is taken up under regional anesthesia, 2 hours, nil per oral. And we ask them to continue the cardiac medications, oral antihypertensives and anti-diabetic tablets. Diabetes, on the day of surgery, we check the blood sugar and we cut the cutoff range, which we fix it is around 200 milligrams per deciliter. And if the patient is a known bronchial asthma, 1 hour before surgery, we advise them to use that inhaler. If not, we nebulize the patient if the patient is having rhonchi. Now coming to the another controversial part, that is antithrombotics in cataract surgery. Antithrombotics, you should understand that is basically there are 2 types, mainly antiplatelets and anticoagulants. Now antiplatelets of late, there are 2 types, aspirin, which is nothing but a platelet aggregation inhibitors through cyclooxygenase enzyme inhibition. And the latest one is P2Y12 inhibitors, they call it as, and under this group comes the clopidogrel, ticlopidine and prasugrel. Now, these antiplatelets, they can be either given alone, that is aspirin alone, or both can be combined, that is called as dual antiplatelet therapy by the cardiologist. Now, coming to the anticoagulants, we think many of you would be aware of this warfarin, which is nothing but an oral vitamin K antagonist. And of late, the cardiologists are prescribing direct acting oral anticoagulants. These are basically of two types you should know of: factor Xa inhibitors and direct thrombin inhibitors. Now, the main implication in patients who are on antithrombotics are bleeding. It can be either block related or it can be surgery related bleeding. Now, with regard to the block related, so you can see here in the latest European Society of Regional Anesthesia guidelines, ESRA we call it as, the blocks, that is the peribulbar and subtenons, they are classified it under superficial nerve blocks, which means they say that withdrawal is not compulsory. It is very important take-home message here. But there are case reports, especially if the patients on dual antiplatelet therapy, there are case reports of retrobulbar hematoma occurring. So you should be careful in these patients. Another interesting article which I thought I will share in this presentation is continuation of aspirin therapy in patients with different incisions of cataract surgery. That is one with corneal incision and another one is a scleral incision, that is you do with this manual small incisional cataract surgery. And they found that in patients with aspirin therapy, there are significant level of subconjunctival hemorrhage, though it is not sight-threatening. So, if you want to discontinue the antithrombotics, this is what has been advised to follow. Antiplatelets means minimum of 5 to 7 days withdrawal can be done in consultation with the cardiologist or the physician, whosoever is treating your patients. Now, anticoagulants, if the patients you want to withdraw it for 5 days with or without bridging therapy. And most importantly, on the day of surgery, INR test is required. Whereas for direct acting oral anticoagulants, INR testing is not required, and they say minimum of 1 or 2 days withdrawal is enough. And for patients with chronic kidney disease or liver disease disorder patients, 3 days withdrawal is advised. Now, some of the patients you might have come across on patients with hemodialysis, chronic renal failure patients on hemodialysis. What is the protocol to be followed? Generally, heparin-free hemodialysis is advised 1 day before surgery so that the fluid stability can be there. Then on the day of surgery, serum electrolytes to be tested. Remember, AV fistula can be there. It should be protected at all times. An IV line should not be started in that side, in that limb, and blood pressure cuff should not be tied on that limb where the fistula is present. Now, another important implication which all the ophthalmologists should be aware is that cardiac implantable electronic devices. There are two types. Some of the patients may come with permanent pacemaker implants. Some of them may come with an artificial implantable cardioverter defibrillators, that is patients with life-threatening arrhythmias. The main implication is electromagnetic interference from external source, that is cautery, which you might use. So always remember, it is better to use a bipolar cautery. The reason is current flow is localized and electromagnetic interference will be less here. So what you should remember, you should check the battery status, and the current recommendations, they say that for AICD, the patient should have visited 6 months at least. And for pacemaker, they say at least within 12 months, they should have visited the cardiologist and had the battery checked for the past 1 year. Now, coming to the preoperative investigations, explain very clearly to the patients about the do's and don'ts during the regional technique procedure. If the patient is found to be anxious, trial of drapings we do in the pre-anesthetic clinic itself. As you can see, the anesthetist, the pre-anesthetic clinic, we do a trial of drapings, especially patients with claustrophobics. We teach the attender also to make them lie down at their home and put a cloth over the face, and so that the patients will be mentally prepared for this. Okay, that is very important thing which we follow at our hospital. And most importantly, if you are going to take up the cases under topical anesthesia, remember they can retain visual sensations a lot. So you should counsel the patients for light and other sensations. So this is one interesting study that has been published long back by us. where we found in patients the topical anesthesia with IV sedation, their satisfaction level is increased, and they find that the light emanating from the microscope is not disturbing if IV sedation is given. That is mainly we give midazolam. So for topical anesthesia also, a little bit sedation is also a good thing. Also, some of the patients might come with kyphoscoliosis. So what you should do, you should make them lie down, and we should make them see how much pillows to be kept under the knees, under the head, and make these patients also mentally prepared that on the day of surgery, this is how you should lie down. Then you choose the plan of anesthesia, whether you are going to do under needle, subtenons, or topical, based upon the various surgical and medical factors involved. Now, coming to the preoperative preparation, that is on day of surgery, the consent form should be taken up, very important. Clear instructions should be given to patients and caregivers with details on what to do and whom to contact should a postoperative complication arises. Most importantly, all the discussions should be documented in the patient record. Also, video information about what is going to happen on the day of surgery and what to expect during the operation. It decreases the anxiety and increases the patient satisfaction. Some of the tips I could give to the ophthalmologist is to make sure the patient has voided that urine. That is very important, because a fully bladder can make the patient restless, and again it can make an upthrust, and patient can become violent also. So make sure that patient is emptying the bladder before you are wheeling the patient in the operating theater. Hearing aid can be used, dentures also. IV line, most importantly, as both the two speakers stressed upon, IV line must be established. Monitors, basically you should connect to a pulse oximeter, ECG, and non-invasive blood pressure monitoring. Most importantly, during surgery, the complete silence should be maintained. Don't utter any alarming words like rise in blood pressure or bleeding inside the eye, because these will make the patient anxious and suddenly they may move and become restless and behave violently also. At the end of surgery, a very clear instructions about oral intake, postoperative pain relief should be given, and you should thank the patient for being cooperative throughout the procedure. That is very, very important. And coming to the emergency trolley, which we set up, this is how we set at our hospital. We have crash cart trolley inside the theater. It has mainly 4 racks. The first rack, we keep emergency medicines alone, which includes adrenaline, atropine, deriflin, dextrose, and dexasteroids, Lasix, magnesium sulfate, potassium chloride, sodium bicarbonate, and most importantly, the myocardial infarction kit. The second rack, we keep IV cannulation items, which includes various types of Venflon, then accessory things like cotton bandage, dynaplaster, scissors, tegaderm, kidney tray, tourniquet also. Then the third rack, we keep the intubation items ready. That includes various sizes of endotracheal tubes, laryngoscopes with various blades, nasopharyngeal and oropharyngeal airways, suction catheters. And the fourth rack, we keep IV fluids. And emergency equipment, basically, I just wanted to cover only one. I think this is the most important thing which all the ophthalmologists should be aware of, because of late, this automated external defibrillator is kept in public places also. It is high time that all the doctors should know about this automatic external defibrillator. The reason is, the early the delivery of the shock, they say, the survival rate of the victim is going to be increased. It is very simple. You should remember the mnemonics PASS, that is PAAS. That is, once you open this AED, there will be a power on button. Attach the pads, it will be very easily put. The diagrams, one is attached to the anterior part of the chest and other is anterolateral. Now, once you attach the pads, automatically a voiceover will come. That AED will analyze the rhythm. That is the only time where we should not perform any CPR, and it will analyze the rhythm and it will say whether any shock is going to be delivered. If shock is delivered, it will deliver the shock immediately and it will ask us to resume CPR. So if AED detects a shockable rhythm, it will give one shock and it will ask us to resume CPR immediately. And AED detects a non-shockable rhythm, it will prompt that no shock is needed and you can resume high quality CPR. So this is a very important, it's the need of the hour. Almost all the doctors should be aware of this AED. So take-home message is that even though cataract surgery is mostly a day case procedure and considered as a low-risk operation, adequate preoperative assessment and optimization sometimes is required. It is very important to educate the patient about the perioperative process that will reduce the anxiety in them. It reduces the number. So thorough preoperative evaluation will definitely reduce the number of cancellation and reduces perioperative surgical and anesthesia-related complications. So if you want to still know more about this ophthalmic anesthesia, I just recommend you all to read this book, Principles and Practice of Ophthalmic Anesthesia, that is available in Amazon. And there is a conference coming up for ophthalmic anesthesia at the Hyderabad 3rd National AAOA. So I request all the ophthalmologists to register for this and get benefited out of it. It is going to be conducted on 7th and 8th of October. Thank you all.
Thank you so much, sir, for a wonderful presentation. And you touched upon so many points which some of us would have considered not very important. Thank you so much for enlightening on so many different points. So now, may I request Dr. Jagdeep Kakadia, sir, again to present his video on oculocardiac reflex. Over to you, Dr. Kakadia, sir.
Yeah, sure, ma'am. Thank you. Of course, I'm no one to speak after these two talks about the oculocardiac reflex, but I'll just share whatever I have. Now, in this section, we will briefly examine how to prevent vasovagal and oculocardiac reflex. Oculocardiac is actually a fatigable double-arm reflex, a combination of afferent irritation of T1 of trigeminal nerve, sensory nucleus being stimulated by uveal or extraocular muscle, and scleral stress receptors or by sudden spikes of intraocular pressure. Trigeminal sensory nucleus stimulation leads to stimulation of motor nucleus of vagus nerve in the brainstem. Hypertone of vagus nerve leads to moderate to severe bradycardia and may be a shock. Please note that the aortic depressor nerve is a branch of vagus nerve, and hence vagus hypertone can also lead to systolic hypotension. Thus, the vasovagal attacks could be bradycardia only, hypotension only, or the combination of the two, which is most dangerous and can be deadly at times. These are sequelae or complications of oculocardiac reflex. Livnox, Dexona, and NSAID can block the afferent pathway, and atropine can block the efferent pathway. Vagal tone and heart rate are inversely proportional. Vagal tone is high in people who have acid peptic disorder, and patients who are on strong antihypertensives, on strong antidepressants, and high-dose anxiolytics can become hypotensive with vagal bradycardia. 0.6 to 1 milligram atropine given 10 minutes prior to surgery can prevent both vasovagal and oculocardiac bradycardia. Preventive dose of systemic atropine is 0.01 milligram per kg body weight. So 0.6 milligram for 60 kg person, 1 milligram for 100 kg person, and 1.2 milligram for 120 kg person. IM or IV atropine injections are almost always 0.6 or 0.65 milligram per ml. So 1 ampule is sufficient for a normal build person. Now, it is interesting to note that 1% atropine eye drops is containing 10 milligrams of atropine in 1 ml, and 1 ml is about 30 drops. So 1 drop is containing 0.33 milligrams of atropine, 2 drops is 0.66 milligram, 3 drops is 1 milligram, 4 drops is 1.3 milligrams. So putting 2, 3, or 4 drops sublingual is equal to giving 1, 1.5, or 2 ampules of intravenous or intramuscular injection of atropine. Off-label sublingual use of atropine eye drops is a well-established old practice with over 92,000 references. Atropine 1% sublingual drops are also officially available in many countries. So we give 2, 3, or 4 drops sublingually depending on the weight of the patient 10 minutes before surgery, and with this regime, we have never faced oculocardiac reflex. It does give rise to dryness of mouth and mild body temperature rise for 3 to 4 hours. And rarely we may get urinary retention in old BPH males, which may need urocare for a day or so. But it is better to have such minor complications than to have a flat line ECG. We all need to have and use a pulse oximeter, preferably with deeper and bradycardia and hypoxia level alarm settings. We should avoid the silent types in OT. They are okay for OPD, but not for OT. Higher adrenaline is anti-anaphylactic, anti-bradycardia, anti-hypotensive, and it gives IOP reduction. By these mechanisms of actions on alpha and beta adrenergic receptors. I also always give a 20 to 40 milligram of prednisolone, about 0.5 milligram per kg, with 20 milligram omeprazole on previous evening. A single small dose of prednisolone gives fearlessness and courage for surgery, gives a nice sense of well-being, we call it Rajapat, keeps all joints and backbones free from pain during the surgery, and gives mild tachycardia. Prevents hypotension, prevents vasovagal and oculocardiac reflex, prevents itching, sneezing, coughing, and odd sensations, prevents shivering and feeling of cold in OT's full air-conditioned environment, and gives very quiet eyes. Such single small dose of prednisolone does not cause dependence, does not cause adrenocortical axis suppression. There is no need to taper, and it may raise blood glucose a little, but it is not a major issue even in diabetics. Most of us are so afraid of using corticosteroids that we don't use even when judiciously needed. Please always remember 4 A's: adrenaline, adrenocorticoid, atropine, and anxiolytics in mild form are antidotes of vasovagal and oculocardiac reflex. Please don't forget that they are our 4 ACEs, with which we can be as sure, secure, and confident as 007 Bond, the James Bond. At the end, we thank you all for your kind attention and patient listening. Thank you, sir.
Thank you so much, sir. Now, may I request the invited discussants to have comments, questions, suggestions? Dr. Chaya Shinde, madam, please.
Yes. After the wonderful talks by the eminent speakers, the knowledge is very well given to us. I have some small questions. Dr. Jayachandran, is medical reference or a physician reference is necessary for all patients before cataract surgery? Should the physician see the patients? Is it compulsory?
Unmute, Dr. Jayachandran.
Mute, please.
Jayachandran.
Oh, sorry. Yeah, it is very important, especially in the present medical legal scenarios. It is very important, medical legal purpose. It is very important to evaluate the patients. As I was mentioning in my presentation, most of the patients who are coming for cataract are elderly with lot of systemic comorbidities that are hidden, especially in developing countries. They would have not even met the first time for the physicians, no? And many times in our hospital, that is the first time we diagnose diabetes also for them. So patients get shocked on saying that you are a diabetic. So that is the health status we are living in. So it is very important to get at least a basic screening by the physicians.
So one more question is, which allergies we should ask, or which allergies which are important as far as the ophthalmology surgery is concerned, or post-operative drugs which will be given to them?
Sorry, allergy, yeah? Allergy. So
and about lignocaine also, how to know whether the patient will be hypersensitive?
Yeah. So basically, we ask the questions in the preoperative anesthetics clinic whether they are allergic to any local anesthetics for that matter. But if we see off late, what we are coming is that, as I was mentioning in my presentation, it is the hyaluronidase rather than the lignocaine. In fact, at our institution, what we have started for the past couple of years is that we started practicing test dose before performing that local anesthetics. That is a very good clinical practice which we have started. And what has happened is that totally 6 cases we have found that ATD to be positive, and all 6 cases were found to be positive to hyaluronidase because it is an animal protein. In fact, we have submitted this to a journal also. So hopefully it gets published soon.
So, sir, when we do lacrimal sac syringing or we check the intraocular pressure when we do the preoperative evaluation, so we'll be putting 4% ignocaine eye drops. So is that sufficient, or we have to do hypersensitivity testing in the patients? So
For drops, you mean? Huh?
Yeah, local drops are enough to know whether the patient will be allergic.
Yeah, that is enough, man. That is enough. That is enough.
Okay, sir. Okay, sir. Okay, sir. Okay.
Dr. Mustafa, would you like to add something?
Well, thank you so much for the brilliant session. As mentioned, some patients may have allergy to the hyaluronidase. I don't know your experience using other adjuncts like magnesium sulfate. We had a local study here where instead of using hyaluronidase, magnesium sulfate that is used to control eclampsia was added to the xylocaine to potentiate the effects of the xylocaine local anesthesia. So what's your experience using them over there? And do you recommend substituting it, especially in patients that have allergy?
No, I don't have any experience with that magnesium sulfate. Rashesh, do you have anything to comment about it?
Magnesium sulfate, I have read about that, but not any authentic results and studies. Sabha will come out with these studies, so we must try that out and experiment. Dr. Kakadia has something to say on magnesium sulfate.
Yes, sir. I have an experience of using magnesium sulfate in place of sodium hyaluronidase because in between for almost 6 or 7 months, the hyaluronidase was not available in India, way back about 20 years back. So we were adding calcium gluconate and this magnesium sulfate, but it is not as effective as hyaluronidase as far as the peribulbar block is concerned. And of course, since 2010 onwards, I have completely shifted to subtenon. So my experience for the last 12, 13 years is only of subtenon. But hyaluronidase is much more effective than the combination of calcium gluconate plus the magnesium sulfate.
All right. Dr. Jagdeep, I don't know, when giving the subtenon anesthesia, I can see you advance your needle posteriorly. And do you sometimes, the chemosis that occur, do you use cotton bud to spread it so that you have wide spread of the anesthetic, or you just wait for it to take before you start your cataract surgery?
No, I see if you have dissected the plane correctly and if you are really under the tenon capsule, there will not be any chemosis. There may be mild proptosis for a minute or so, but within a minute, the block spreads. If the cannula has gone between the tenon and the conjunctiva, then there will be a chemosis. So the moment I start seeing chemosis when injecting the subtenon block, we come out and give pressure and allow the chemosis to disperse and then dissect it further to expose the sclera even better and then go again. And when we are going into the subtenon space, we always keep the cannula very snugly touching the sclera so that you are never going through the tenon. But if the primary dissection is good and if you have exposed the sclera very well, there won't be chemosis ever.
All right. What's of the experience of the kinetic anesthesia, topical and intracameral, preservative-free xylocaine for cataracts, SICS?
Yes, yes. For all phaco cases, I use topical anesthesia. But if I have to convert, or if I have to do SICS, ECC, or squint, or pterygium, or any other surgery, then I use subtenon block, or in a very uncooperative patient.
All right. My last comment is to Dr. Jachandran. In pre-operative evaluation of the patient, you said you rely on 200 milligram of the sugar level on the day of surgery. Maybe if the patient is not a non-diabetic or not a medication, but do you consider the glycated hemoglobin too before you take your patients?
No, we don't do that HbA1c because many times if we see the guidelines also, they never go by that HbA1c. HbA1c mainly it is meant for the prognosis purpose. So on the day of surgery, the current status of the blood sugar plays a very important role. So if you are going to go by HbA1c, then definitely we will not be able to do a single case because some of them it might require months, couple of months to get reduced. But so it is not, we never go by HbA1c. On the day of surgery, we go.
Xylocare has been shown to be relatively safe especially in inadvertent injection into the vitreous. What do you advise someone that's having glove rupture during peribulbar anesthesia or retrobulbar? Should he go ahead and complete the surgery or suspend it and go back a later date and do it?
What is that?
Maybe Dr. Jadip, technique of anesthesia. So, okay, we can have local globe penetration and the injection of xylocaine in the vitreous. So, in that instance, should the cataract surgery proceed or we should delay the surgery for another day?
No. It should be postponed because if you are doing phaco in a posteriorly perforated globe, there will be a posterior vitreous prolapse, there could be RD, there could be multiple complications. So I would not proceed if there is a globe.
Actually, we had a patient that had globe rupture following local anesthesia, and fortunately, using the blade, we were able to do a tunnel, complete the cataract surgery, and after some time, the xylocaine absorbed, and the patient's vision improved. So, and there is another second scenario where a patient also had inadvertent penetration of the globe. We suspended the surgery, but subsequently he came back with elevated intraocular pressure that made him to have secondary glaucoma. Subsequently, we lost that eye. So I was just wondering.
So if the globe rupture was only a puncture wound in the sclera,
yes, it's puncture actually.
But it was a linear globe rupture with the needle passing and creating a linear wound, you would have ended up in a more.
It's actually a puncture.
Yeah, so with the puncture you are saved.
All right, thank you.
Dr. Kakaria sir, you mentioned about using a specific forceps while giving a subtenon block. Can't we use a routine tissue holding forceps for that?
We can, but we can use even limbs. So what
Yes.
I do is I use limbs forceps, but I take a nail cutter nail polish file and blunt the tooth of the limbs forceps a little bit so that it becomes atraumatic. It does not cause a puncture wound in the kidney. So we can definitely use limbs, not a problem. But when I have to present it online for a YouTube recording, I have to speak more what is classically described.
Yeah.
In fact, I tell you, quite often I use Simcoe cannula to induce subtenon. You can use Simcoe cannula, 2 cc on the main hub and 2 cc on the side hub, and inject 2 cc first from the main hub, then ask the assistant to inject the remaining 2 cc from the side hub. So you can use Simcoe cannula. You don't need a dedicated subtenon cannula because Simcoe cannula has 2 ports. And the curvature of the Simcoe cannula is exactly matching the globe. So,
right.
I don't think any surgeons are using Simcoe these days.
Sir, I use disposable Simcoe for my subtenon block when my subtenon cannulas are over.
Dr. Chotalia?
In fact, I had a limitation of time, otherwise I would have shown that video also. But maybe in some next webinar, I'll show the Simcoe cannula. But it's very simple. It's very simple.
Dr. Chotalia, sir, would you like to ask some questions or add to the...
As such, all the speakers have given excellent talks and have enriched our knowledge to a great extent. But I would like to ask my dear friend Jagdeep, as such, he has already given the profile of steroids as such, as an anti-inflammatory. But as he's been using it along with this anesthetic cocktail, so won't it affect any healing or that wound?
No, sir. It is, see, it is, first thing is dexamethasone. It is not a depot steroid like the Tricot. Dexamethasone gets absorbed within 12 hours from the site of injection, number one. Number two, the concentration of dexamethasone is 0.25 milligrams per ml, which is very, very low, even for the systemic absorption. It is just a drop or 2 drops of the dexamethasone injection in 4 ml block. So I don't think that is going to hamper the healing ever. And this practice of using dexamethasone in a small dose in the retrieval bar, I have inherited that from my teachers and my professors. And Dr. Chotalia, I want to remind you, I have seen you injecting 2 ml of dexamethasone retrieval bar for severe optic neuritis and for severe papillitis. And I remember that you had given to Mohinder Amarnath, the famous...
Surinder Amarnath.
His brother. His brother.
Exactly.
Lala Amarnath's son. So Dr. Chotalia, when he was a resident at Vijay Medical College, had given... Surinder Amarnath had bilateral severe optic neuritis. He lost the vision completely. And I have seen Dr. Chotalia giving 2 ml dexamethasone twice a day for 8 days. So giving retrieval bar injection of dexamethasone, we used to use it with arlequin and dexamethasone as a combination in our residency days for optic neuritis and papillitis. So, I mean, it's my personal preference, but I would strongly recommend that if you add a little amount of dexamethasone, you get such quiet eyes and you never get this hyaluronidase allergy. Never. I have that experience of using it in more than 65,000 surgeries over the last 36 years. And you never get that hyaluronidase allergy.
But unfortunately, arginine is not available.
Arginine is now not available.
Almost 2 decades. But
it's available as tablet.
It is unfortunate.
It's available as tablet, but not available as injection.
Not as injection, yeah. Otherwise, you are right. I have used in many of my private patients.
I have seen you. You were my senior, or 5 years senior. But when I was in the ophthalmology term and you were a resident, I have seen you giving that injection.
Right.
Dr. Arora, sir, would you like to comment on anything or any suggestions, any questions?
Yeah, first of all, let me, am I audible?
Yes, sir.
Yeah.
First of all, let me compliment Dr. Anil Shah for the wonderful session. I have few observations before I take what I intend to say. First is about Dr. Jayachandran. I mean, Indian Ophthalmologic Association's founder and secretary. I mean, this is something new to me. I mean, pardon me for my ignorance or innocence, whatever, but compliments to you. And Dr. Kakadia, about the one you mentioned about the cocktail of lignocaine, sensorcaine, hyaluronidase, and DEXA. DEXA was something new to me, and I really think I'll have a word with you later on also, but that sounds really interesting to me, putting that cocktail of DEXA into this. Now, coming to the point which I want to emphasize on, we have covered different types of anesthesia. Let me come to one very common and very popular, though not very commonly practiced, that is a topical anesthesia. believe me, I've been doing topical SICS in more than 12 years now. Though I don't do much of SICS, but if at all I have to do an SICS, topical SICS is definitely a possibility, and one can actually comfortably go ahead with doing a topical SICS, because basically, what are the concepts? What are the hindrances? First is you cut the conjunctiva, patient will complain of pain. You cauterize the blood vessel, patient might complain of pain. Third, iris touch either by your instruments or your nucleus delivery through the main incision. That is the third possibility. So if you can tackle these things, do not cauterize your assistant flowing in the fluid to wash away the blood. Conjunctiva, you may just give a small nick, and the surgical technique of delivering the nucleus out of the bag into the anterior chamber and out of the nucleus, out of the main incision. If you can manage those steps comfortably, then topical SICS is a wonderful surgery if at all you have to go for that SICS. And one more thing I would like to add, we have not covered that lignocaine jelly, which surgeons used to do. Only thing is it's slightly toxic to the cornea. So if you can place that bubble or that maybe 1 cc of lignocaine jelly in the conjunctiva, let it be there for about 30 to 40 seconds, and with a Johnson's bud, you can just wipe it out, trying avoid to come in contact with the cornea. That also have a good anesthesia purpose.
Sir, that 4% LOX is even more effective than the lignocaine jelly.
That's what I'm saying. But
the 4% topical LOX, the 4% lidocaine injection to be used as topical LOX is far more effective than putting a gel.
Mute kar do.
Dr. Paranjpe sir wants to ask something.
Yeah, may I ask a couple of questions?
Please.
One question is to Rasesh and Priya. The question is, you both specifically used one term in your talk, the pressure on the globe. Most of the ophthalmists talk massage to the globe. Are you very specific about mentioning the word pressure, or it is just interchangeable, like massage or pressure, either of the two will do? I personally feel we should give pressure and never massage the globe. So will you please clarify on that? And second question is to our another guest speaker regarding ophthalmic surgery. So first question, please.
Yeah,
Dr. Jagdeep and Rasesh. Globe pressure and globe massage, do you make a specific difference between the two?
Yes. When I say, I never use the word massage. If you only once I mentioned the word.
You use the word pressure, light pressure.
Like all the technique for putting the super pinky ball, or many people use various devices to give a pressure over the eyeball. See, that is only a sustained pressure. When we call it massage, I have seen people doing it, put the two fingers and they fluctuate, and all that, the eye starts becoming soft, and I think it's dangerous for the zonular support and for the lens support. So these are the cases where on table, after massage, may get donesis. So I strongly recommend not to do a massage and fluctuating pressure. A sustained pressure I recommend. And every 2 minutes you release this to prevent the ischemia. And that's what probably super pinky was mentioned for that only. It was mainly designed for that.
Yeah, I agree, sir. I agree with Dr. Rasesh Diwan. But my pressure is 15 seconds on and 15 seconds off, instead of 2 minutes on and 2 minutes off. But it's only a vertical pressure, not massaging the eyeball or not squeezing the eyeball, because when you ask your assistants to squeeze, we don't know how heavy-handed the assistant could be. It could be variable, and someone might induce the zonular laxity.
May I add something there?
Please, sir.
May I add something? In the recently operated eye or in the traumatized globe, massage is obviously out of question because you will bring something out. Secondly, when you massage, you unnecessarily increase the and so some physicians have said make up. Thirdly, choroidal vessels by giving a very forceful massage. So should be a very light massage, light pressure on the globe, go on increasing the globe pressure and go on releasing the globe pressure. By that, you never continuously compress the central retinal artery, and you know by to your fingers that globe is getting soft. That much is sufficient. And for SICS and phaco surgeries, severe hypotony is not mandatory now.
Mostly more now, no one needs severe hypotony nowadays. Previously, when opening the whole large, different
in fact, we operate in a hypertensive state of the globe.
Maybe I'll little add in the technique. What
and the second question regarding the presence of anesthetics as a standby.
Yeah, that we'll discuss later on. First, I want to add little to the practice. What I do in peripheral work is you saw the video, I gradually start very slowly inject. The moment it stops, it closes the eyelid, I withdraw the needle in the same path, like I had gone a little curve, I withdraw in the same path. So it doesn't perforate any vessel. So there's minimal chance of periorbital hemorrhage. And then I put my thumb over the lower orbital rim, and I don't give at all any pressure over the eyeball. There are two reasons. One is we have injected about maybe 4 to 6 ml of fluid inside the orbit. There's an extra space occupied by the fluid. So we have to give the time for that to get absorbed. So there are chances of more oculocardiac with the pressure immediately if you put on the eyeball. And second is I put it pressed over the lower orbital rim. So with that, the drug doesn't spread on the subcutaneous area lower down. It makes a lock over the lower orbit, so the fluid remains within the orbit. So maybe my 4 or 5 ml, one prick periorbital bulb nearly spreads very well in couple of minutes. After that, I put a 4-layer gauze piece and give a very gentle pressure. And that too, sometimes if I find chemosis, either medial side or lateral side, I increase that pressure a little bit on that with a finger, but sustained pressure, never massage or fluctuating pressure. So that is what additionally I do. So with the lower volume, I give a peribulbar spreading all over.
We still apply pressure by using the Horner balloon. Sustain pressure over the eye.
Right.
Following peribulbar.
Yeah. The second question.
Yeah.
One question is to Dr. Jayachandran regarding the presence of anesthetics in ophthalmic OT.
I will say it is a must, sir.
Yes, sir.
It's a must.
No doubt about it.
No doubt about it. So wherever I go, they ask the two questions: the presence of anesthetics, presence of IV line. Both, they should go hand in hand. So we'll never know when the patient will become restless or suddenly become claustrophobic. Especially, we had one case, it's actually a vitreoretinal case where a long time the patient was quietly normal. At the end of the surgery, suddenly, without any reason, patient become restless and violent. Then we sedated with IV. Okay, the next post-operative day, I asked the patient what has happened. Actually, what happened was, at the end of the surgery, there was some minimal conjunctival loss. So there were some utterances like high bleeding inside the eye. That was a single-eyed patient. So this is what I mentioned in my slides also. Absolute silence should be maintained. Don't prompt unnecessary words. This will provoke the patient, and this will in turn, you will require the help of the anesthetist to give some IV sedation. This is a very important thing.
Hello, permission.
Yes, sir. Dr. Marathi, sir. Yes.
Hello, I got the question in continuity with that. I think standby anesthetics most of the times, which was discussed in the past, which was not the routine thing. Nowadays, everybody is keeping routine anesthetics. My first question is, because both of the speakers are anesthetists today, when the anesthetist is present in the OT, even ophthalmologists in the past, they have started, when they were taking their UG, PG education, they have started giving a local anesthesia. And even anesthetists, most of the times, they might not have learned. So whosoever is more expert, like ophthalmologist or anesthetist, because in other type of surgery, like ortho or cardiac or general surgery, you people are giving anesthesia. But while ophthalmic cases are there, who is supposed to use the anesthesia?
Very good
Ophthalmologist or
question.
anesthetist?
Very good question. Actually, at our institution, we anesthetists only give the blocks, sir, especially for vitreoretinal cases. And wherever I go to the conference, I encourage other non-ophthalmic anesthetists also to learn the ophthalmic blocks, because the blocks, I believe that strictly it should be more of anesthetist oriented, especially needle blocks. Whereas subtenons, I say it's a 50-50. Both surgeons as well as anesthetists can give. So needle blocks, definitely anesthetists, non-ophthalmic anesthetists especially, they should start learning. So the anesthetist standby means most of the non-ophthalmic anesthetists, they think that what is a big deal? Just like that, they can go, stand and come. No, it is not like that. It is high time they should all learn performing blocks, because if any complication arises, it is finally their responsibility to take over the case. So it is high time for all the anesthetists to learn the ophthalmic blocks.
Because in the past, most of the anesthetists, they were not used to give that local anesthesia, but the ophthalmologists were expert in that. Now the question comes when the anesthetist is present. So who has given the anesthesia in the medical legal past, medical legal problem?
So actually,
that is the issue.
Keeping this in mind only, I have developed those simulators along with the IIT. So I want to teach all the ophthalmologists and the anesthesiologists, especially non-ophthalmic, to learn this in stimulators so that later on they can practice in humans.
My another question is, like in Dr. Jagdeep Kakadiya sir's presentation, he said that pre-operative atropine will help in preventing oculocardiac reflex. Whereas Dr. Rashesh Diwan sir's presentation, it was said that previously given atropine will not prevent oculocardiac reflex. Rather, the role of atropine is after oculocardiac reflex. I think these are a little bit different opinions. So, expert's opinion, please.
May I add something there?
Please.
When we see a bradycardia on the table before giving any anesthesia, say heart rate below 60, we'll call it as a bradycardia. Then what I do is ask the patient to take 3-4 deep breaths, clench his feet, smooth the leg movements, and see if his heart rate is increasing. If that is there, so from 60, if it is going to 68, 70 to 72, that means that his bradycardia is not refractory. Because in the beta blocker patients, the dose is such scheduled that they will never get a tachycardia. But here I'd see to it that they they go into tachycardia, so that there is every chance that atropine will increase the heart rate if at all it is required. And second, one thing I do is before giving any anesthesia, on both the globes, I give light pressure and see the monitor. If by giving both pressure 65, then it means he is very much vulnerable to develop bradycardia, severe bradycardia. There is one report or one case study, repeatedly giving globe pressure, that oculocardiac reflex will get refractory or it will get fatigue, and afterwards you will not get bradycardia after globe injection or a peripulvar injection. So that one step I do extra, give 3-4 times globe pressure, observe the heart rate. If it is coming down, then keep on giving pressure like that, and then it will recover, and then you can give peripulvar anesthesia.
Yeah, actually, what is the terminology?
One more question, please. Please, one more question. Besides Hylex and Dexona in Xylocal as an additive, what other pharmaceutical additives we can use? One medicine I know that is clonidine, and second medicine I know that is soda bicarb, which I use very routinely.
What is the first, sir? We got your voice.
Injection clonidine.
Clonidine.
Alpha 2 agonist.
Like nowadays, clonidine, another is dexmedetomidine. Both are available. They both help to prolong the block and gives a very good extension to the analgesia postoperatively. And I have used a couple of times in past. For cataracts, we don't use because it's a short procedure. It is not very painful also postoperatively. So, and our incidence of giving peripulvar in cataract is very, very negligible, maybe 1 out of 100. Most are topical only. But dexmedetomidine, what I observed was you have to be very careful. It's a wonderful drug. It's a wonderful additive for other regional anesthesia. And now it's also been advocated for prolonged procedures like vitreoretinal surgeries, where patient is not going to go home immediately also. Because the other problem is bradycardia and hypotension, which may last for 1 or 2 hours after chlorine and dexmedetomidine, both drugs. It's a more modern drug. That's why normally our cataract short procedures, they walk from the table. At that time, they get postural fall if they have received this dexmedetomidine or clonidine. That's why I stopped using it. But I see it's a wonderful additive for longer procedures like vitreoretinal surgeries. For analgesia, vitreoretinal surgeries, we use more of bupivacaine. And Jayachandran probably would agree that 100% bupivacaine without mixing with lidocaine, but we add hyaluronidase in that, and we have prolonged. But only thing we have to give the block little early, 15 minutes, 20 minutes before. So it lasts very long. Sometimes till next day you have ptosis. So that is third thing. Third is usage soravicap. Soravicap's usefulness is changing the pH, particularly when you are using lidocaine adrenaline combination. Lidocaine adrenaline is acidic. So when you add soravicap little recommended quantity, the onset of action, because there is more free drug available to bind to the tissues. So the onset you get quicker than regular block, particularly when you are using lidocaine adrenaline. It doesn't help when you are using bupivacaine. What was the next other question?
What is the next question?
You put 4-5 questions at a time. We also
one question is there. One question is there. Mixing bupivacaine and xalocaine in one syringe.
Yeah.
Because as I know, both have different pH, so they are pH incompatible. So you may lose the efficacy of each drug separately.
Definitely, sir. I have published a study long back. It is in the Journal of Ophthalmology itself. It is in vitreoretinal surgeries, where we mixed lignocaine and bupivacaine in one group. The other group we used only lignocaine, and in the another group we used bupivacaine alone. As you rightly said, what is happening is that 2% solution lignocaine will become 1% and 0.5% will become 0.25%. And in fact, the conclusion of the study is there is no clinically significant difference in the onset of action by mixing. In fact, we noted by mixing, the duration of action is getting reduced. You understand? So mixing doesn't play any role. In non-ophthalmic surgeries, if you see, anesthetist never mixes. I don't know why in ophthalmology alone still, that cataract surgery, they say 4 ml lignocaine, 4 ml bupivacaine. Still the default it goes. Many times I have told the ophthalmologist also, you should not mix. But I think this is a take-home message that both the local anesthetics should not be mixed. Okay, it doesn't serve any purpose at all. And as you rightly said, no, sir, that repetitive vagal stimuli, you said no. The term is called as vagal escape. They call it as the terminology is called vagal escape. That is, it is the tendency for the vagus nerve to get adapted to the repetitive stimulus. The other point which I just wanted to add upon to this oculocardiac reflex is that I think Rashesh would be agreeing with me. It seems that patients who had this OCR, there are 10 to 15 times more liable for the nausea and vomiting. This is because of oculoemetic reflex also can be there. So what Dr. Kakidia said was 4 A's. You should also remember 5th A, anti-emetic should be given. So those patients who are with OCR, remember, nice new set, MSET and ondansetron should be given. That will take care of nausea and vomiting also. The other thing I just wanted to say is gentle traction should be given to the extraocular muscle. Gentle. That is the most important thing. And sometimes many of the surgeons used to say the tight bandage, no? Especially after the glaucoma surgeries. Remember, this tight bandage also, where we switch off the monitor, that time also OCR can come. Any tight compression of bandage. That is a very important thing. We have come across a case where soon after surgery was over, monitor was switched off, tight bandage was put, and then immediately the patient complained of some sweating like thing. We connected to the monitor. We saw that bradycardia was there. So it is important that bandage should not be put tight also. That is important message. I want to add up.
So it is analogous to scrotal injury.
pressure over the eyeball, you said you check on the monitor, right?
Yeah.
Now, let me tell you, I am the Director of Training, National Director of Training, Indian Distillation Council Federation, and research is going on. Like we do the carotid massage for supraventricular tachycardia. Now, pressure over the eyeball also has been recommended to control the supraventricular tachycardia. So, heart rate has gone to 160, 170. You give a gentle pressure for 5 seconds and observe on the monitor. So, that's a nice test you are doing for the preventing oculocardiac.
Yeah, sorry, gentlemen, because of want of time, we should stop our discussion here because we have two videos to watch.
One last point I will raise. With due respect to anesthetist, in our OT, everyday anesthetist is a must. But still, as a joke, I would say that instead of having their sight on the cardiac monitor, their sight is on their mobile phone. So, in a way,
Sir, nowadays their monitors are on mobile.
Can I just ask Chandra, what was the inference of his study? One was lignocaine, one was bupivacaine, and one was mixed. What was the inference of the study?
That is plain bupivacaine is more than enough rather than mixing lignocaine and bupivacaine, sir. That was the conclusion of the study.
Okay. As it is rightly said, as goes the anesthesia, so goes the surgery. So we must be very, very, very particular about giving whatever anesthesia we want to give in a proper way. Thank you, Rutuja.
Thank you, sir.
Now we'll watch the video by Dr. Shekhar Paranspe, sir. Mr. Rahul, can you please play the video?
You want me to
solve
play
peripulvar injection.
Okay, let me try to. I will share my screen. Or you can share the screen from my video. This is a 1.5 minute video presentation. You can do it.
Sir, I will share or you are sharing, sir?
I will do it. Share the screen. Yes. Yeah. Here what I am doing is, this is a 3 ml xalocaine, where xalocaine with adrenaline hylase and 0.3 ml of soda bicarb. And here I am asking the patient to bring out his tongue and then bite it. As you can remember, in our childhood days, our grandmother always used to say, whenever we are hurt, bite the tongue, bite the tongue. That is what, now you can see the lady is not winking at all. And then subcutaneous xalocaine is given. And now I will give the peribulbar block very slowly, 1 ml for 10 seconds. So this 3 ml will go over a period of 25 to 30 seconds. And the needle will go with the weight of the needle, no extra pressure. And then I moved the syringe here and there to confirm that I am not in the globe wall or in the globe. I am slowly infiltrating, and while doing so, I am looking at the monitor to see whether there is bradycardia or not. Now, with the left hand, I have steadied the syringe and needle. So there is no risk of any movement. So I am monitoring, and at the same time, I am looking if the lid is drooping, upper lid is drooping. If once I see the upper lid is drooping, that is the end point of anesthesia. And now immediately finger is kept on the globe, and then with a sterile pad, which is kept on the globe, light pressure is maintained on the globe. I am sitting on the right side. Most of the surgeons sitting on the head side, but here sitting on the left side of the patient, I find it very convenient to give proper block. Thank you.
Thank you for the video, sir. Now there is a video from Entor. Mr. Rahul, you can play your video.
Paranspe, sir, can I share the screen?
Yes. How to do that? Your screen is paused.
Stop sharing, you can see.
Yeah. I have done that. Yes.
Mr. Rahul?
Rahul?
Yes, sir.
Yeah.
You can share the video. Now, may I invite our chairpersons, Dr. Prakash Bharati sir and Dr. Rajesh Joshi, for the concluding remarks.
Hello, I think it was a wonderful session. Almost 2 hours we have crossed, and it was very healthy discussion. And so many points were there as take-home message, and experts have given their knowledge, thorough knowledge, which was beneficial to each and everyone, those who are the participants here and the delegates here. It was a wonderful session. Congratulations to all the speakers, all the participants. Thank you. Thank you so much.
Rajesh Joshi, please. Dr. Rajesh Joshi.
Not there?
Yes, he's there.
Unmute.
Yeah.
Your concluding remarks, some comments.
Yeah, in fact, it was really a wonderful webinar. And I thank everyone in ISMSICS and then all the speakers who have really enlightened on this very much needed topic. In fact, there are as many types of anesthesia as there are operating surgeons, and whatever type of anesthesia you use, with no or with anesthesia next day, what matters is the patient vision and the patient comforts. And ego should be kept behind. And it's really a wonderful webinar. Thank you so much.
Thank you.
I would request the co-moderator, Dr. Pankaj Shah, to propose the vote of thanks.
Yeah, thank you, Dr. Rujita. It was really a wonderful webinar. I thank all the speakers, Dr. Kakadia sir, Dr. Diwan sir, Dr. Jayachandra sir, for enlightening us. Almost 2 hours we had discussion on anesthesia, where rather more on phaco or cataract, we are discussing on the preoperative stage. Thank you for giving us all the take-home messages. It was a wonderful discussion with all the discussions, Dr. Chaya Shinde madam, Dr. Chotalia sir, Dr. Gopal Arora sir, Dr. Mustafa. Healthy discussion and taking many take-home messages. I thank all the chairpersons of this webinar, Dr. Prakash Marathe, Dr. Anil Shah sir, Dr. Shekhar Paranjpe, and Dr. Rajesh Joshi. I thank MSICS Maharashtra chapter office, and I also thank Entod for giving us the opportunity to host the webinar along with you, and my co-moderator, Dr. Ruchita, for being a co-moderator for this session, and a wonderful audience of the webinar also. Thank all of you.
Thank you. Thank you so much.
Thank you very much.
Good night.
Thanks for the wonderful session.
Good night, everyone.
Good night, sir.
Thank you.
Good night.
So much.
Bye, good night. Thank you, sir. Thank you very much.
Good.
Very happy to be
Night.
here. Thank you so much.
Thank you, sir. We'll leave the meeting, sir.
Okay.
Yeah. Okay.
Thank you.